conversion therapies for gender diversity in children, i.e. any therapeutic attempt to compel a gender diverse child through words, actions, or both to identify with or behave in accordance with the gender associated with the sex assigned at birth, are harmful, and we repudiate their use. Damn, that feels good. So the WPATH, which is the World Professional Association for Transgender Health, is a nonprofit organization that basically sets the parameters and the rules for how you should handle trans health. Like, they say this amount of time should elapse between like them asking for surgery and them getting surgery or whatever, like basic shit like that. Like, you must be on hormones for this amount of time before you can whatever, like rules kind of like that. I don't know what all of the rules are specifically because I didn't follow the WPATH path when I got hormones and shit originally. I've always done everything informed consent style. But this is like, it informs what doctors are supposed to do so that doctors then have an idea of how to treat transgender patients. And if they follow this guidelines set, then that can prevent them from getting sued for malpractice if they're following the rules. So WPATH was founded in 1979, which is pretty cool. And yeah, they establish like new standards of care every so often. If you haven't yet hit like on the stream/video, please consider hitting like on the stream/video. That helps me out a lot. Patreon and donations are also super helpful. Informed consent follows WPATH guidelines, though. I just didn't, I guess, like, I assumed that there were some rules at some point of requiring you to get some amount of therapy before you could get hormones, but maybe I'm just thinking about insurance requirements, because insurance requirements are even more, I don't know. They're different. Do you watch Callan Conrad? Yeah, I do watch Callan Conrad. I appreciate Callan and all the very, very, very difficult work that they do. So the WPATH released new standards of care, which are used not just by doctors to figure out care, but by lawyers in court. So let's read some of this shit from Aaron in the Morn, who is like way more patient than me in having gotten, because there's like so many pages of this, and I just want to know some of the stuff. Some notes though. 1 letter required, down from 2 for surgeries. Does this mean that like even like, is there no such thing as informed consent if I want bottom surgery? Am I gonna have to get at least 1 letter from a fucking person? Like, I've been trans for 13, like I've known that I'm trans for 13 years, and it's just they're still gonna make me get a goddamn whatever. Explicit allowance of informed consent. Okay, so maybe explicit allowance wasn't there before. No watchful waiting, which is conversion therapy. Like, so it's noteworthy that the WPATH is specifically saying watchful waiting is not recommended. You should not do that. Watchful waiting is basically this idea that if you just let the kid be dysphoric for their entire teenage years, then by the time they're an adult, they will just stop being trans. Like, it's just like hoping that they will stop feeling shit about themselves, I suppose. So one thing that's awesome here is that the recommendation for hormone therapy has been lowered to 14 years of age. I am assuming that it was previously at 16. The call out to rapid onset gender dysphoria is not in this version of WPATH as far as I can tell. A number of TERF adjacent doctors wanted to insert it there. So here's this. Previous guidelines regarding gender-affirming treatment of adolescents recommended partially reversible gender-affirming hormone therapy could be initiated at 16 years of age, but more recent guidelines suggest there may be compelling reason to initiate affirming hormones prior to the age of 16, though there are limited studies on youth who have initiated hormones prior to 14. A compelling reason for earlier initiation might be to avoid prolonged pubertal suppression. So there is some concern that if you're on hormone blockers for too long, it could hurt your bones. So if you start cross-sex hormones earlier, then it would prevent those concerns. So given the potential bone health concerns and the psychosocial implications of delaying puberty, as described in more detail elsewhere. That's pretty cool. What's up, Slaps Hungry Bears? Welcome in. So they do cite the rapid onset gender dysphoria study, but pretty much just smack it down, really. One researcher attempted to study and describe a specific form of later presenting gender diversity experience. That's the citation. However, the findings of the study must be considered within the context of significant methodological challenges, including that 1, the study surveyed parents and not youth perspectives, and 2, recruitment included parents from community settings in which treatments for gender dysphoria are viewed with skepticism and are criticized. However, these findings have not been replicated. Yeah, they've not been replicated. Yeah, I'm so glad that they called that out. They're like, because the idea of rapid onset gender dysphoria was this, parents of older teens or even young adults, like 20-year-olds, 23-year-olds, were like, my child just spontaneously came out as trans and decided to cut off their breasts and stuff, like, and it was just really cringe, and they just assumed that it was some kind of social contagion because queer people tend to want to be friends, basically, like TLDR. There are new longitudinal studies appearing in WPATH, and these 2 paragraphs right here will provide a lot of support for many court cases in the U.S. Ooh, this is exciting. Longitudinal studies, evaluating participants at different stages of gender-affirming treatments. Some participants may not have started medical treatment yet. Some have been treated with puberty suppression, and others had started affirming hormones or even done surgery. Given the heterogeneity of treatments and methods, this type of design makes interpreting outcomes more challenging. Nonetheless, when compared with baseline assessments, the data consistently demonstrate improved or stable psychological functioning, body image, and treatment satisfaction varying from 3 months up to 2 years from the initiation of treatment. So this study went on for about 2 years, studying like how are people's internal wellness and stuff going while like, and starting at various stages. So like any trans person at any stage of transition, whether they were early on, whether they had so far as gotten surgery within that 2-year period of time, or 3 months to 2 years period, consistently data demonstrates improved or stable psychological functioning, body image, and treatment satisfaction. So people are basically down with their periods. It's not what I was trying to say. My words just fucked up in my mouth, and I'm not going to try to fix it. How dare queer people be friends with each other? True. To conclude, although the existing samples reported on relatively small groups of youth and the time to follow up varied across studies from 6 months to 7 years. 7 years is a good follow-up period for a study like this. This emerging evidence base indicates a general improvement in the lives of transgender adolescents who, following careful assessment, receive medically necessary gender-affirming medical treatment. Further, rates of reported regret during the study monitoring periods are low. Taken as a whole, the data show early medical intervention as part of a broader combined assessment and treatment approaches focused on gender dysphoria and general well-being can be effective and helpful for many transgender adolescents seeking those treatments. Hell yeah, dude. Could have fucking told you that shit. Amazing. I'm glad to have the validation through studies, though, and not just like me knowing a lot of trans people. For adults, the 1-year waiting period for surgeries has been lowered to 6 months. This indication is also removed for non-binary patients who decline HRT. Oh! We suggest healthcare professionals assessing transgender and gender diverse people seeking gonadectomy consider a minimum of 6 months of hormone therapy as appropriate to the transgender person's gender goals before the trans person undergoes irreversible surgical intervention, unless hormones are not clinically indicated for the individual. Because sometimes you physically can't take hormones without increasing your risk of something else. But this is cool. Does this cover the non-binary thing? The Endocrine Society Clinical Practice Guidelines advise a period of consistent hormone treatment prior to genital surgery. While there was limited supportive research, this recommendation was considered to be a good clinical practice as it allows a more reversible experience prior to the irreversible experience of surgery. I mean, that kind of makes sense. They're basically saying, like, before you dive all the way into getting surgery, like, you might want to try something that is going to bring you into that same type of congruence of gender, but, like, is less, like, irreversible, I guess. I mean, I kind of get it. For example, there can be changes in sexual desire after genital surgery that removes the testicles. In this context, reversible testosterone suppression can offer a trans person a period of time to experience the absence of testosterone and decide if this feels right. Like, right. Yeah, that makes sense. Does she go into any further detail about the... Another indication that WPATH guidelines are good is the reaction from GC, TERF, right-wing, trans-med adjacent side. So she didn't have a link or a screenshot here specifically of the, I can't go through the whole thing myself with the time that I have right now, to find all the stuff, but it's cool that she's claiming the indication is removed for non-binary patients who decline HRT, because it just means that like you don't have to do testosterone in order to get a hysterectomy, or like you don't have to do testosterone in order to get top surgery, which you already don't necessarily need for top surgery. But yeah, so here, let's see. Standards of care. It is one of the most shocking indictments of ideology infecting medicine that I have ever come across, says this weird person. If Mermaids is not a medical organization, as heard in court this week from its chair, why is CEO Susie Green a co-author on latest international standards of care for trans health? She could serve on two different... Is she doing that co-authoring in her capacity as CEO of Mermaids, or does she just have like multiple things going on in her life? Anyway... This is WPATH 8, suggesting amputation of the penis and removal of testicles as part of vaginoplasty for boys as young as 13. Does it actually say that? Or is this sensationalism? Not only are they doing this to young people, they want to go much, much younger. It seems that the people that drafted this document at WPATH are the ones who need psychological help first. Mutilating children certainly cannot be the answer to a hopefully happy adult life. There are way too many detransitioners to keep going on this path. Yeah, Aaron is also just saying, like, if it tells you anything about like what, oh my God, I want to look at the whole thing. If this tells you anything about how good these changes are for trans people, just take a look at how fucking pissed off the TERFs and transphobes are. They're very upset. So yeah, this is 206 pages long, y'all. But I do want to look at some specific things. Whoop, camera's out. Hold on. She's back? Are we back? Okay, sorry about that, everybody. No big deal. I'm just looking at the table of contents right now. I kind of want to look at children and non-binary. I think those are the two chapters that I want to look at. And also intersex, maybe. Where someone said that detransition was mentioned in here. Is there... I'm not seeing it in any of the chapter titles here. But I would be curious... if there is a section of eunuchs, yeah. I'm not sure. There should be. It may not be a chapter. Yeah. What chapter would it be under, do you think? If you all can read this. I love the changes, but when I go to find out more info, I get swarmed with fear-mongering articles, swings, and roundabouts. I mean, that's a good reason for us to publish this video as a segment on the channel. I should probably do that with this video tomorrow. Are you able to Alt F4 and find the phrase? I mean, maybe. Detransition. It's in here a number of times. It's in here 36 times. Why is that so tiny? Statements of recommendations. Okay, here we go. So I do basically like, I want to look here at the detransition segment, and I want to look at the section on children because they've changed some of those guidelines and I'm curious what they've specifically said there. And I also want to look at the non-binary section. So we'll end on that. Recommending healthcare professionals assessing adults who wish to detransition and seek gender-related hormone intervention, surgical intervention, or both, utilize a comprehensive multidisciplinary assessment that will include additional viewpoints from experienced healthcare professionals in transgender health and that considers, together with the individual, the role of social transition as part of the assessment process. Many trans adults may consider a range of identities and elements of gender presentation while exploring their gender and considering transition options. Accordingly, some may spend some time in a gender identity or presentation before they discover it does not work, and then later they want to change it. Some may experience a change in identity over time. Healthy and reasonable process for determining the most comfortable and congruent way of living, which is informed by the person's gender and the context of their life. This process of identity exploration should not necessarily be equated with regret, confusion, or poor decision-making. That's cool, because a trans adult's gender identity may change without devaluing previous transition decisions. Damn! Hot fucking damn! Holy shit! That feels good to read. I like that. I know that's a difficulty that a lot of detransitioners have, where they're like, I am, there's no way for me to narrativize this without being like upset and feel regretful, and people are telling me that I'm all mutilated and shit. So that's cool. They refer to it as they were also refer to retransition as another way of framing it. That's cool too. I like that. Let's see. Any other changes in their identity? While this exploration continues, gender-affirming treatments that are irreversible should be avoided until clarity about long-term goals and outcomes is achieved. Fair enough. The decision to detransition appears to be rare, according to multiple studies. Estimates of the number of people who detransition due to a change in identity are likely to be overinflated due to research blending different cohorts. For example, detransition research cohorts often include trans adults who chose to detransition because of a change in their identity, as well as trans adults who chose to detransition without a change in identity, meaning that they detransitioned because of a lack of social support. What little research has been conducted to systematically examine variables that correlate with a trans adult's decision to halt a transition process or to detransition, a recent study found the vast majority of trans people who opted to detransition did so due to external factors, such as stigma and lack of social support, and not because of changes in gender identity. There you go. They may choose to detransition because of oppression, violence, and social relational conflict, surgical complications, health concerns, physical contraindications, a lack of resources, or dissatisfaction with results. In such cases, mental health professionals are well placed to assist the trans person with these challenges. Cool. Just like on Wikipedia, right? Yeah. It's disproportionately rare decision. The absolute numbers of detransitioners may increase. The percentage of people seeking to halt or reverse permanent changes should remain static and low. Expected to remain static and low, which makes perfect sense. Let's see if there's anything else specifically interesting on this section. That's just like, that's cool. You know, it's validation of detransitioning. It is vital that people who detransition for any reason be supported. It should be remembered, however, this is a rare occurrence, and this literature shows consistently positive outcomes for the vast majority of trans adults who transition to a gender that is comfortable for them, including those who receive gender-affirming... What is GAMSTs? Gender-affirming... I don't know. I'm assuming that means surgery. I don't know what that means. GAMST. All your best guesses... for what GAMST mean. I know a lot of detrans people who don't regret their transition. Yeah. I'm assuming it means surgery. Yeah. Okay, so that'll lead us directly into adolescence. That's cool. That previous chapter was just going to lead us right into talking about adolescence, which is the next subject I wanted to look at here. Let's see. Or no, adolescence is not what I want to look at. What I want to look at is children. I want to know... Although I guess this part does help in determining the age stuff. One of the key challenges is looking at the quality of evidence, evaluating the effectiveness of medically necessary gender-affirming medical care. Oh, here, it stands for Gender-Affirming Medical and Surgical Treatments, GAMSTs. Okay. As of this chapter's writing, there were several longer-term longitudinal cohort follow-up studies reporting positive results of early i.e. adolescent medical treatment. For a significant period of time, many of these studies were conducted through one Dutch clinic. The findings demonstrated the resolution of gender dysphoria is associated with improved psychological functioning and body image satisfaction. There you go. Like, that's pretty much what I expected to find. So let's see. Different studies evaluated individual aspects or combinations of treatment interventions and included gender-affirming hormones and surgeries, puberty suppression, puberty suppression affirming hormones and surgeries. Oh, so it's like all these different studies looked at these different things. The 2014 long-term follow-up study is the only study that followed youth from early adolescence from pre-treatment around the age of 13 through young adulthood through to the age of like 20 years old. This was the first study to show gender-affirming treatment enabled transgender adolescents to make age-appropriate developmental transitions while living as their affirmed gender with satisfactory objective and subjective outcomes in adulthood. There you fucking go. There you fucking go. That's awesome. It was a relatively small, select, and socially supported sample, but the results were quite convincing. Yeah, given that we know that it's lack of social support that often makes people detransition, like having a socially supported sample means that you'll likely have like basically across the board positive results. There's so much to get through. Okay. Let's see. Cross-sectional studies provide another design for evaluating the effects of gender-affirming treatments. One such study compared psychological functioning in trans adolescents at baseline and while undergoing puberty suppression compared to that of cisgender high school peers at two different time points. At baseline, the trans youth demonstrated lower psychological functioning compared with cis peers, whereas when undergoing puberty suppression, they demonstrated better functioning than their peers. That's interesting. This study demonstrated that transgender males who started testosterone had lower internalizing mental health symptoms such as depression and anxiety compared with those who had not started testosterone treatment. That's cool. All right. Basically, like a lot of positive results. This is just basically like breaking down, like here's many examples of concluding, although the existing samples reported on relatively small groups of youth and the time to follow up varied across studies from 6 months to 7 years, this emerging evidence base indicates a general improvement in the lives of transgender adolescents who, following careful assessment, receive medically necessary gender-affirming medical treatment. Further, rates of reported regret during the study monitoring periods are low. Taken as a whole, the data show early medical intervention as part of a broader combined assessment and treatment approaches focused on gender dysphoria. Come on, girl. My camera is just blanking out again. Can be effective and helpful for many transgender adolescents seeking those treatments. Okay. I mostly just want to figure out what their specific guidelines are for age restrictions and stuff. If we can find any more detail. Because, like, people are saying, like, they're recommending we do surgeries on kids at, like, as young as 13. And it's like, I don't really think that that's what they're advocating. They might say, like, children as young as 13 should be able to receive gender-affirming medical interventions and surgical treatment. But they, you know, they're not necessarily advocating specifically that children that young should be given the full 9 yards, because they still indicate in other parts of this that they think that an adult even should be on hormones for a while first to see what it's like to not have those parts or whatever, right? Like, so obviously the restrictions for children are not going to be significantly looser than that or whatever. They're still going to want you to try something reversible before you try something irreversible. That was already established when we were reading before. Oh, I bet this is something that the TERFs are going to freak the fuck out about. Oh, this is a good one. I bet they're going to hate this. Hit like on the stream if you think that the TERFs are going to hate this. We suggest healthcare professionals provide transgender and gender diverse adolescents with health education on chest binding and genital tucking, including review of the benefits and risks. Trans youth may experience distress related to chest and genital anatomy. Chest binding, chest padding, genital tucking, and genital packing are reversible non-medical interventions that may help alleviate this distress. Thank you so much, Slaps Hungry Bears, with the tier 2 sub. That's really kind of you. Hell yeah. Hell yeah. That is unironically gonna help me find a new place to live. So thank you. Here we go. So chest binding involves compression of the breast tissue to create a flatter appearance of the chest. TERFs bitch about this so much. So much. They complain about it so much. They go like, oh no, these girls are hurting their rib cages by binding their chests. Like, oh my God. But here we have like some info about it, right? So binding methods may include use of commercial binders, sports bras, layering of shirts, layering of sports bras, or use of elastics or other bandages. Currently, most youth report learning about binding practices from online communities composed of peers. Providers can play an important role in ensuring youth receive accurate and reliable information about potential benefits and risks of chest binding. Talking about safe binding practices, monitor them for negative health effects. There are potential negative physical impacts. Youth who bind report many benefits, including increased comfort, improved safety, and lower rates of misgendering, which is considered clinically significant here, and I very much appreciate the WPATH for that. Common negative health impacts of chest binding can include chest pain and back pain, shortness of breath, and overheating. The more serious negative health impacts such as skin infections, respiratory infections, and rib fractures are uncommon and have been associated with chest binding in adults rather than adolescents. They're going to hate that. Methods that are considered unsafe for binding include the use of duct tape, ace wraps, and plastic wrap, as these can restrict blood flow, damage skin, and restrict breathing. That's awesome. That's just like, I mean, I've known that for years and everything. TERF, I must be able to see adolescent breasts. They care so much about the lesbians having access to those breasts when those ripe, pert teenagers come of age. You know, that's what they're really concerned about. Genital tucking is the practice of positioning the penis and testes to reduce the outward appearance of a genital bulge. They really hate this too. I don't really understand why they hate tucking so much. I think it's because it takes away all of their power to tell whether someone has a penis or not. Like, because tucking is just so effective at making your junk look flat. So, yeah. And we watched that video with the drag queen recently. So the whole premise is that, like, the testicles go up into the inguinal canals, and then you pull the genitals back and, like, tape everything down. And that holds everything in place, you know? And they just fucking hate that so much. Let's see. Limited studies are available on the specific risks and benefits of tucking in adults, and none have been carried out in youth. Previous studies have reported tight undergarments are associated with decreased sperm concentration and motility. In addition, elevated scrotal temperatures can be associated with poor sperm characteristics, and genital tucking could theoretically affect spermatogenesis and fertility. Although there are no definitive studies evaluating these adverse outcomes, further research would be needed to determine the specific benefits of tucking in youth. Cool. That was fun. I like that they had a segment about tucking and binding, because it is relevant medical care. Wow, it just honestly feels really affirming to have it validated that way. So, let's move on to children. That was the adolescence portion. Let's scooch down to children and see what they have to say about that. And then, like I said, the last section we'll cover today will be the non-binary section. So oh my God, this is long. Oh wait, here we are. Is this it? Yeah, okay, chapter 7, children. I just blew right past it. Thank you, M, for your $1 contribution, or no, the $3 contribution for hidden vids. I am considering deleting that function on the channel, but I appreciate your assistance anyway. So let's see. Children. These standards of care pertain to prepubescent gender diverse children. These are based on research, ethical principles, and accumulated expert knowledge. Principles underlying these standards include the following: One, that childhood gender diversity is an expected aspect of general human development. That two, child gender diversity is not a pathology or mental health disorder. 3, diverse gender expressions in children cannot always be assumed to reflect a transgender identity or gender incongruence. Totally fair. 4, guidance from mental health professionals with expertise in gender care for all children can be helpful in supporting positive adaptation as well as discernment of gender-related needs over time. 5, conversion therapies for gender diversity in children, i.e. any therapeutic attempt to compel a gender-diverse child through words, actions, or both to identify with or behave in accordance with the gender associated with the sex assigned at birth, are harmful, and we repudiate their use. Damn, that feels good. Damn, okay. That was good. Hit like on the stream if you liked that moment. That felt good to say. So, unlike pubescent youth and adults, prepubescent gender diverse children are not eligible to access medical intervention. So they become adolescent and start having the medical stuff applied to them at the onset of puberty, basically. Therefore, when professional input is sought, it is most likely to be from a healthcare professional specialized in psychosocial supports and gender development. So this is focused on psychosocial practices. Okay, so maybe we don't even need to look at this section because it has explicitly stated that this section is not going to talk about medical intervention because prepubescent youths are not eligible for medical intervention because they don't need any. Like they don't need medical intervention because they haven't had any of the effects of puberty developing yet. So that's very cool. I appreciate that. Oh, holy shit. There's 69 likes on the stream right now. So cool. Yeah, I don't think I really feel the need to read any more of this section because the concern that I had with it was just the, oh boy, was just the specific medical transition aspects of it. So here we go. Non-binary. This is an umbrella term referring to individuals who experience their gender as being outside of the binary. This term is predominantly but not exclusively associated with global North contexts and may sometimes be used to describe indigenous and non-Western genders. This includes people whose genders are comprised of more than one gender identity simultaneously or at different times, such as bigender. Those who do not have a gender identity or have a neutral gender identity, such as agender or neutrois. Those who have gender identities that encompass or blend elements of other genders, such as polygender, demi-boy, demi-girl, and or who have a gender that changes over time, such as a gender-fluid person. Non-binary people may identify to varying degrees with binary-associated genders, such as a non-binary man or woman, or with multiple gender terms, such as non-binary and gender-fluid. Damn, this is so thorough. Yeah, like, absolutely. This is, man, I mean, it's just based on observation, right? Like, it's not like this is anything you wouldn't have known if you were paying attention, right? But, yeah, anyway, so genderqueer, first used in the 1990s, is an identity category somewhat older than non-binary, which had first emerged in the late 2000s. Genderqueer may sometimes be used synonymously with non-binary or may communicate a specific consciously politicized dimension to a person's gender. Cool. Okay, so this is just showing like a pretty significant demonstration of understanding here. Oh, damn, this is cool. Recent studies suggest non-binary people comprise roughly 25 to over 50% of the larger transgender population, with samples of youth reporting the highest percentage of non-binary people. That's cool. That's really cool. Okay. So I want to like find some of the parts here where they're talking about, okay, so we're talking about medical care now. The need for access to gender-affirming care. Some non-binary people seek gender-affirming care to alleviate gender dysphoria or incongruence and to increase body satisfaction through medically necessary interventions. Some non-binary people may feel a certain treatment is necessary for them. Whoa, shit, did not mean to click. No, go back. Go back. No. Okay. Get back to the page. Okay, I clicked something by accident, and now here we are. Some non-binary people feel medical necessary, blah, 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 whilst others do not. And the proportion of non-binary people who seek gender-affirming care and the specific goals of that care remains unclear. Okay. It's the role of healthcare professionals to provide information about existing medical options that may help alleviate gender dysphoria, which may best fit for each individual person. Cool. Motivations for accessing or not accessing medical interventions, including hormones, surgeries, or both, are heterogeneous and potentially complex and should be explored collaboratively before making decisions about physical interventions. That's fair enough, yeah. For example, some transgender women have no need of vaginoplasty, while some non-binary individuals who are assigned male at birth may need and benefit from that same intervention. Yeah, so that was cool. I skipped a sentence. The need of an individual to access gender-affirming care and procedures cannot be predicted by their gender role, expression, or identity. Cool. Okay, let's see. I'm skimming through the need for an appropriate level of support. Oh my gosh, hold on. Good. Okay, good. That felt good. All right, there was another one. That was all good too. Okay, cool. Let's see. Ooh, okay, here's an interesting section. Gender-affirming medical interventions for non-binary people. In contexts where a particular medical intervention does not have established precedent, it is important that before the intervention is considered, the individual is provided with an overview of the available information. So yeah, with regards to estrogen therapy for non-binary people who are assigned male, it's important to note that the possibility of breast growth cannot be avoided. Although the extent is highly variable, this should be made clear if a non-binary person seeks some of the other changes associated with estrogen, but does not want or is ambivalent about breast growth. Similarly, for non-binary people assigned female who may access testosterone, who want some changes but not others, it should be recognized that if facial hair development is needed, genital growth is inevitable. That's so good. Okay, statements of recommendations now. Recommending that healthcare professionals provide non-binary people with individualized assessment and treatment that affirms their non-binary experiences of gender. Healthcare professionals should avoid making a priori assumptions about any client's gender identity, expression, or needs for care. Also be mindful that clients' non-binary experience of gender may or may not be relevant to the assessment and treatment-related goals. We recommend healthcare professionals consider medical interventions for non-binary people in the absence of social gender transition. That's pretty big, okay. We recommend healthcare professionals consider gender-affirming surgical interventions in the absence of hormonal treatment unless hormone therapy is required to achieve the desired surgical result. This is the one section that I was really excited to look at. Definitely really excited to look at. The trajectory of hormones before surgery is an option across a range of surgical interventions. Some non-binary people will seek gender-affirming surgical treatment to alleviate incongruence and increase body satisfaction, but do not want hormonal treatment or are unable to undergo hormone therapy for other medical reasons. Currently, it's unknown for which proportion of non-binary people these options apply. If the surgery has some specific association with non-binary people, hold on. The surgery which has some specific association with non-binary people is mastectomy in non-binary people who have not taken testosterone, although testosterone is not a requirement for this type of surgery, and some non-binary people who are assigned female may need breast reduction. As an example of a surgery for which at least a period of hormone therapy may be necessary is metoidioplasty, which enhances the enlarged clitoris produced by testosterone therapy. Yeah, like that's literally the only like reason that you would absolutely need to be on hormones before a surgery is if like your metoidioplasty shit would be way too small, you know? Surgery and postoperative care. Check this, for more detail on whether hormone therapy is necessary for various surgeries. I hope that it's not. Yeah. Oh shit. 4 gifted tier 1 subs. Holy shit. Thank you, Slaps Hungry Bears. I appreciate that. Wow. Yeah. I might have to check chapter 13 if it doesn't specify here if whether hormone therapy is considered necessary before phalloplasty. Although I have done at least 6 months of hormone therapy. So maybe I've already passed that hurdle because I've done like 4 years of hormone therapy actually. Procedures addressing the internal reproductive system include hysterectomy, unilateral or bilateral salpingo-oophorectomy, and vaginectomy. Hormone therapy is not required for any of these procedures, but hormone replacement therapy is advisable in those individuals undergoing a total gonadectomy. Yeah, because you need to have hormones. Here we go. For phalloplasty, while there is no surgical requirement per se for a minimum period of testosterone treatment, virilization or the absence of virilization of the clitoris and labia minora may impact the choice of surgical technique and influence surgical options. Okay, that's interesting. What does virilization mean? Hold on, I have to Google that. Define virilization. The development of male characteristics. Okay. Okay, so the testosteronization or lack thereof of the clitoris and labia minora may impact the choice of surgical technique and influence surgical options for phalloplasty. Okay, cool. That's cool. Ooh, here, cool. Additional surgical requests for non-binary people assigned male include penile-preserving vaginoplasty with preservation of the testicles, and procedures resulting in an absence of external primary sexual characteristics, such as penectomy, scrotectomy, orchiectomy, etc. The surgeon and individual seeking treatment are advised to engage in discussions so as to understand the individual's goals and expectations, as well as the benefits and limitations of the intended procedure, to make decisions on an individualized basis and collaborate with other healthcare providers who are involved. That's cool. I'm so glad that they would make it. I wouldn't think phallo would be possible without or a little t. So 2 different surgical procedures for bottom surgery for trans men and other non-binary people assigned female. Metoidioplasty is the one that uses the clitoris to make the penis, like the actual growth. So they tend to be small. Like the effect that you get is like it's literally a micropenis. Phalloplasty is a skin graft from somewhere else. So like when I get mine done, it's going to be a skin graft from my arm. And there is like a nerve hookup, but that's it, you know? As far as like, you don't actually have to change, like it just doesn't affect anything. Like the testosterone doesn't affect strictly the phalloplasty itself. So I don't know if that makes sense in particular, but recommending healthcare professionals provide information about the effects on future fertility. Of course. Yeah, of course. Talk about futility. Okay, here's a section on eunuchs. Okay, that was basically everything that I wanted to look at about this. There is so much to go through. It's 260 pages long. I'm not going to be able to go through it. I've been talking for so long that my throat hurts a little bit. So we'll get off of this. That's the lowdown on the WPATH changes. They have changed some of the age restrictions. Who is actually going to be following these standards? Any doctor who currently follows WPATH standards is going to use this official guidance. Like when your doctor is a chucklefuck who has never treated a transgender patient before, when they go to find out how to treat trans people, they go here. Like this is the standard of care. And it's not only what the doctors use to help determine what is appropriate for you transition wise, like what is appropriate for you age wise. This is also what is used by lawyers who litigate these cases. It's published by the World Professional Associated for Transgender Health, which is WPATH. So if there is ever a lawsuit, like if the mom is affirming of the kid, but the dad isn't, if the dad decides to sue the hospital for giving their kid hormones, then the lawyers will say this was medically indicated. You know, here's the WPATH guidelines. This is what has been like, I believe that this is international. I don't think that this is just based in the United States. Yeah, it's the World Professional Association. So like this is what the entire world should be following as far as standards of care for trans people. This is what is recommended, and many countries use this as their like essentially the legal document by which they determine what things are acceptable and not acceptable. So yeah, hopefully that helped give you some ideas about some of the like positive directions that these changes are going toward. Reportedly, a lot of the reason why they changed the age ranges for teenagers was so to try to help like prevent doctors from being sued for trying to keep the teenagers on track with their peers. Spider with the tier 2 sub, thank you. Yes, enjoy your dicks. Absolutely. There you go. We got another dono. Damn, you all are like killing it tonight with the donos. Now we're over the 1/4 mark. Hell yeah. Are tucking and binding the universal standard of care, or does the individual get to decide if that applies to them or not? Mountains of the Moon, it's basically just like, the reason that they have that in there is because some people try to say like tucking is dangerous, and they're saying like, if you want to reduce your dysphoria, you can tuck. We don't necessarily understand all of the potential negative effects of that. There are some that there could be, but it doesn't seem to be like, it doesn't seem to cause cancer or anything, you know? So, it's like can be recommended if the person needs that kind of management of their care. Does that make any sense? Like, it's not saying that like binding is the thing that's like, that the doctor is going to prescribe and you don't have any choice but to bind your chest, you know? Like, you could bind, you could just wear sports bras, you could get top surgery, you know, like there are a number of different ways of addressing that form of dysphoria. All of that is genuinely so cool. It feels so affirming to know that these are the changes that are happening. Yeah, trying dark green this month. I definitely think that it is a positive step. Yeah, She Who Knows No Name, you put it really well. The idea with the tucking and binding is almost you're going to do it, it's not going to kill you, so here's how to not fuck it up really bad. Yes, like binding can be medically recommended to help with dysphoria. However, binding with an ACE bandage is not medically recommended because the risk of injury is so great that it may outweigh the risk or the benefit that you're getting from having your dysphoria alleviated by binding with an ACE bandage. You know, don't bind with duct tape. I didn't see them mention trans tape or KT tape in the binding section. Let me look at that again. Binding. If binding is employed, youth should be advised to use only those methods considered safe for binding, such as binders specifically designed for the gender diverse population. Methods that are considered unsafe for binding include duct tape, ACE wraps, and plastic wrap. So this doesn't mention athletic tape, but I'm kind of assuming that that's like gonna fall under the duct tape in terms of like could potentially damage your skin. Yeah, I'm wondering about the trans tape thing, but it's not mentioned here. But yeah, I personally consider athletic tape to be a pretty dangerous thing to do. Yes. So this does cover like a hugely diverse range of things. And basically this just constantly encourages, the WPATH guidelines currently just constantly encourage, like, you should talk to your fucking patient and listen to what they say and then like help them achieve their goals safely. Like basically I think fundamentally the sort of ideology underlying this is like informed consent. Like, we recommend certain amount of waiting periods for just like, yeah, before you go chopping your testicles off, maybe you should try a testosterone blocker to see what it's like to live with no testosterone in your body, right? Like, I kind of get that. Yeah. Crossing out the dicks. But other than that, like this whole thing is just like patient-directed care, informed consent. Binding sounds like such a pain in the ass. Yeah, it's not the same as wearing a bra, but it's definitely not necessarily the most pleasant, which is why I won't do it. Totes worthy for the subs, donos, and Patreon shit. Thank you. I appreciate. I work relatively hard to make sure I bring you the news, so it definitely feel good to feel like you're doing something useful. Chopping the dicks, true. Does this mention therapy? So, yeah, we can, let's see, way back at the top here. Is there a chapter specifically about therapy? Because it did mention therapy in one of the sections that we were looking at where it says, watch and wait therapy is emphatically not recommended. Like, it's not recommended at all. I don't think that there is a so there is the chapter on mental health. It's the last chapter. So there is a chapter on mental health in here, since we had some curiosity from Dwoozle. Oops, I accidentally typed in the thingy. So this chapter is not meant to be a substitute for chapters on the assessment or evaluation of people for hormonal or surgical interventions. Many trans people will not require therapy or other forms of mental health care as part of their transition, while others may benefit from the support of mental health providers and systems. Some studies have shown a higher prevalence of depression, anxiety, and suicidality among trans people than in the general population, particularly in those requiring medically necessary gender-affirming medical treatment. However, trans identity is not a mental illness, and these elevated rates have been linked to complex trauma, societal stigma, violence, and discrimination. In addition, psychiatric symptoms lessen with appropriate gender-affirming medical and surgical care, and with interventions that lessen discriminatory and minority stress. So that's basically like the introduction to this section on mental health treatment. We recommend that mental health professionals address mental health symptoms that interfere with a person's capacity to consent to gender-affirming treatment before gender-affirming treatment is initiated. So there are some kind of mental health disorders that would be considered like a barrier to a person's ability to do informed consent. So you would need to, for example, treat underlying psychosis before moving forward with gender treatment, I guess. Also recommend mental health professionals offer care and support to trans and gender diverse people to address mental health symptoms that interfere with a person's capacity to participate in essential perioperative care before gender affirming therapy. The inability to adequately participate in perioperative care due to mental illness or substance use should not be viewed as an obstacle to needed transition care, but should be seen as an indication that mental health care and social support need to be provided. When mental health symptoms or substance abuse exists, mental health professionals assess the potential negative impact mental health symptoms may have on outcomes based on the nature of the specific gender-affirming surgical procedure. Yeah. Recommending healthcare professionals counsel and assist trans and gender diverse people in becoming abstinent from tobacco nicotine prior to gender affirming surgery, because using tobacco can fuck up your surgical results, which you don't want. You don't want that. Yep. So there is a section on mental health care and therapy, and it basically says trans people, you can have therapy and it's not bad, you know? But don't do conversion therapy. Like, it explicitly denounces conversion therapy and watch and wait therapy. As a non-binary dude, my ideal medical care would be vaginoplasty with a complimentary dildo molded from my former dick and a strap, so I can just have it when I want. I have heard of women doing that. I've heard of women doing that. I'm sure that some non-binary people have done it as well. But it's like, I guess it's really difficult to. We're done with WPATH now, I guess. We're going to move on to something else. We're doing Dick's chat now. Thank you so much to everyone who supports the channel. This is my full-time job. You are all very much appreciated. And I want to especially shout out some of my patrons. We have Tiago Nascimento, Mersh Rolvog, Brandon, Maurice Taylor, Jovian F. Gaudreau, Bean, Heather Clarkson, Amanda B., Sarah A., Wellington Marcus, R. Halverson, Athiet, Decoy Duck, Michelle Winter, Suzanne Maynard, Nova, Elizabeth Bartell, and Mr. Atheist.